So yeah, I'd like to thank Devon and the committee for inviting me to do this, and hopefully you'll find this an interesting conversation. So the outline of the talk, I'm going to do it in two different parts. So the first part of this is going to talk about, sort of mainly to the title, introduction to the nitrate, nitrite, nitric oxide pathway, a look at inorganic nitrate supplementation and exercise performance, and then look at an ergogenic aid, and by that I mean in healthy, populations. And then we'll sort of move on to what we actually think are factors that contribute to and influence the performance and response to inorganic nitrite. And then what about in clinical populations as a therapeutic to sort of hopefully compensate for some of the deficits that they may have. And then, we'll do summary conclusions. And then for the second part, I'll focus a little bit more on a clinical population as an ideal model for what we think that could benefit from inorganic nitrate supplementation. And so we'll sort of walk you through that as well, and look at exercise performance, the acute, chronic, and then exercise training in terms of rehabilitation. Can we help in rehabilitation in addition to exercise? And then sort of at the very end, we'll take a look at a new area what is this contribution of stored nitrate in muscle and nitrite in muscle, and does that contribute to exercise performance? Okay, so, we know that in different models that we can have a beneficial effect on blood flow and blood pressure regulation. By nitric oxide can affect this system. We know it's involved in neurotransmission. We know that NO plays a role in mitochondrial respiration, and we also know muscle contractility and even circular and calcium reuptake in muscle. And so there's a lot of areas that could possibly apply to exercise that this may be very beneficial in. And so endogenously, without any supplementation, the pathway that we have in the vasculature at least, because obviously it's in a lot of different places, the pathway that we have for this is converting L-arginine to nitric oxide and L-citrulline via eNOS. And I've put this in a nice sort of light red color here to indicate that we need oxygen for this to happen, okay? And then this NO then can be used to a lot of different biological actions, vasodilation, calcium handling, glucose uptake, cellular respiration, contractile function, a bunch of different factors. Also, it can be oxidized. So it can be oxidized to nitrite, NO2 minus here, and can be oxidized to nitrate, NO3 minus. And for a long time, this is all we thought that happened. So we kind of looked at this as markers, especially nitrite, of where nitric oxide was or has been as a rough marker. And so that's kind of changed in the last sort of 10 or 12 years, that now we know that if we supplement, so an exogenous source of nitrate from the diet, and you can do this chemically, you could also do it in natural products, for example, the DASH diet that's recommended to reduce hypertension and good for diabetes, has a lot of inorganic nitrate in it. And so, what happens here is we have this, and I've put hypoxia, but it doesn't need to be hypoxia. It just means that you don't need to have oxygen, oxygen is not required for this. So, we have bacteria in our mouths that can convert nitrate. We swallow it, it goes around the system, it comes back up, we convert it, and we swallow it again as nitrite. And I'll show you that in a second, but we can reduce it to nitrite. And then we know that sort of in a low oxygen environment, that deoxyhemoglobin, in muscle deoxymyoglobin, basically protons, an acidic environment, electron transport enzymes, and xanthine oxidase can all convert this to NO. So there's now two pathways that we can look at here. So quickly walk you through this. If we consume inorganic nitrate, we have this sort of two-pass approach. So first we swallow it, it goes into the circulation, and I've just put a little figure here from some of our work a few years ago that to sort of highlight, we looked at a crossover study, 4 different conditions where we used mouthwash. So we used control, we used antiseptic, sort of like, I think it's Listerine, we used Chlorophyll, which is a little bit stronger, and then we used prescription chlorhexidine. So I actually had to go get a prescription for chlorhexidine, which was an interesting conversation with your physician. And so, if we look at that, and you can see that there's no difference in this first pass through of plasma nitrite in the 4 conditions. So then what we find is 25% of this is the nitrite is concentrated in the salivary glands, about 75% is excreted in the kidney. But we have this second pass mechanism where as we produce saliva, bacteria in the mouth convert this to nitrite, NO2-, and then it passes again into circulation. And if we look here, the 4 different conditions, you can clearly see that now we're looking at plasma nitrite much lower in the 2 different conditions that were stronger mouthwash, right? Not so much in the first 2. And what I haven't put up in here as well, this also showed the ones that converted to nitrite and the nitrite levels went up also had a lowering of blood pressure, okay? So we have this idea that now, you know, we know nitric oxide is good for lots of different things. We can give dietary nitrate, it's converted to nitrite. It can be converted to nitric oxide, especially in conditions where, you know, oxygen may not be as freely available, such as exercise. And then we can have all these effects, vasodilation, calcium handling, contractile function, all of these different things, which what we know from this audience can now convert to exercise economy, performance, fatigue resistance, and metabolic efficiency. Okay, so this is a pretty neat model. So obviously there's been a tremendous amount of interest in this. And I've quickly sort of done a search here with the search terms on the bottom of nitrate, exercise, and then a visual inspection of studies and done it by year. And there are like thousands of these. So I'm probably way underestimating. But what I've tried to do is over the last sort of, I guess 13, 12 years now really, looked at healthy, the black bars, studies in healthy populations, only with exercise, that we're looking at an exercise outcome, and then also in clinical populations. We're calling mainly cardiovascular, and we'll sort of investigate this as we go along. So you can see that these numbers have gone up, and you've seen this in the news, you've seen it, you know, there's a lot of stuff happening here. So I try to divide these up. What is the actual benefit from inorganic nitrate supplementation? And the title of this talk is it an ergogenic aid? So, if you look at the definition of an ergogenic aid, intended to enhance physical performance, stamina, or recovery, and it's intended to enhance, and it's usually healthy subjects or athletes. You know, there's not a dysfunction, there's not a system that's not working, we're not trying to repair something, we're actually trying to enhance something. So if we look at a systematic review in 2020, and this was by Senefeld and Michael Joyner's group. So they looked at 80 different studies. The numbers when you go through the paper are a little bit confusing, so bear with me here. This is what it reported. So they had 80 studies, 118 data sets, which covered 1,179 men and 156 women. So there's obviously a dearth of studies in females. And these are all the studies listed here. And what they sort of found is most of the studies, 76 from 111, slightly different numbers here, but 76 from 111, or 68%, did not observe a difference in performance, but no studies reported worsened performance with nitrate supplementation compared to placebo. So at the end of this, they said it is an ergogenic aid in healthy populations because we have an effect size, wrong button. We have an effect size here of 0.17. So it's sort of way down here below small. So you can cast this as like very small or a trivial effect size. But when you think about how we go about this, really this is driven by not having a reported worse performance taking beet juice. So they may not got any benefit, but they didn't get worse. And so when I look at this kind of data, I'm sort of saying, well, if I had an athlete, you know, and we've had these conversations, and I want them to take something that will give them an ergogenic benefit, I want to know that it actually works, right? I can't ask them to take 20 different things and then say, you know, you're good. Like, just keep doing this. So they'd literally be rattling as they run down the track. So I think you've got to bear that in mind. And if we dig into this in a little bit more detail, so here's some earlier studies, and they kind of divided this up a little bit, what I think is a little bit more sort of interesting to look at, or a little bit more informative, should I say. So they looked at maximal graded exercise tests. We know an incremental workload till fatigue. Time to exhaustion, where they had a fixed submaximal workload and exercise till fatigue, and then a time trial performance where it was a set distance and they had to do this, get there as quick as they can, right? But it was at least over 3 minutes, any of these. And this is what they found, if I summarize the data here. So Hoon in 2013, and you've got the numbers of subjects in each, numbers of studies here, sorry, in each of these. And so if we look, what they found was for the graded exercise test, they found no benefit. When you look at the time trial performance, again, they found no benefit. For time to exhaustion, we had this positive effect, and Campos divided athletes up versus non-athletes and found no effect in the athletes and compared with the non-athletes. So overall, you get a little bit of a picture of what do we think the success rate is when we do these studies. So if we now look at it as a therapeutic, so related to the healing of disease, and so we call it restorative or corrective. And so now I'm talking a little bit more about clinical populations. Can we give this as a therapy, and obviously as an exercise therapy, to go along with exercise as an outcome? So if we try to look at this and say, okay, if we're going to divide it this way up, what are the factors that actually predict that we will have a benefit? So we can look at the fitness level of the subjects. We can look at the fiber types utilized in the exercise and activity that they're doing. We can look at the oxygen availability for that activity as well, or delivery, how well can they deliver oxygen to the tissue. And then I've put these in sort of blue, and we'll look at these real quickly. What dosing regimens seem to be more successful? And then the issue of converting nitrate to nitrite and the variability that we have there as well. So we'll kind of walk through these. So if we look at fitness level, this is a study by Simone Porcelli. In 2014, and he broke this up into low, moderate, and high fitness groups, and you can see the VO2s up here, and they give them 5.5 millimoles of nitrate for 6 days. So when you look at the graphs that we have here, just to sort of orient you, this was their constant load exercise at a set work rate. And what they found in the low fitness and the moderate fitness group, they found that it actually reduced VO2 for a set workload, suggesting that they're becoming more efficient, and it's having this beneficial effect. Didn't see this in the higher fitness group, no effect. And if you look at this on the graph below, as the sort of, if you look at 0 here, the lower the VO2 was to start with, the greater it was reduced at the same workload following nitrate supplementation, suggesting that less fit may benefit more. They also looked at a 3-kilometer time trial, so obviously the faster you can do this, the better. And again, we see these benefits in the low and moderate fitness groups, and when you look again at who benefited most, there's a nice correlation between this baseline fitness and how much their time trial came down. So it would suggest to us less fit individuals have a larger benefit from consumption of dietary nitrate. So also, what about the fiber type utilized? So, this sort of classic idea is we're not going to start recruiting, only as we increase exercise intensity, we're increasing, total muscle, active muscle linearly. And, we're always engaging slow twitch, type 1. We're sort of starting to engage type 2A gradually. And then only at these higher intensities are we starting to engage the really fast glycolytic fibers. So if we look at this, in this study, 11.2 millimoles acute dose by Rimmer in 2016, and as the power output went out to revs per minute, they only saw a difference following nitrate, a reduction here, a difference in higher intensities. So again, suggesting it was only when they were employing fast twitch fibers. If you look at repeated sprintability, this is Simone again. They did this 8.2 millimolar for 6 days, 6-second sprints and 24-second recovery. Again, they start to see a beneficial effect only after repeated bouts, when they're starting to tire and they're starting to rely on anaerobic metabolism, fast twitch fibers a little bit more. So, is there any other data that sort of would lead us towards this fast twitch preference in nitrate supplementation and activity? So Hernandez looked at increased intercellular calcium handling in fast twitch muscle and found that only in fast twitch did supplementation give us a benefit in force production. And then some stuff with Scott Ferguson here looked at vascular conductance in rats. This is in rats. And looked at sort of by infusing labeled microspheres, where did they go when we were exercising this? With nitrate, we could label it, and then where does it actually go? And what you see here is the increased blood flow and capacitance went to fast twitch fibers, not slow. And I'm sorry if you can't see this really as clear as it looks on the slides when I put them together. But believe me, it only went to fast twitch fibers. And then again here, they looked at also this PO2 of the microvessels, and again found that it reduced this partial pressure of oxygen in the microvessels only in the fast twitch fibers, not in the soleus, but it did in the gastrocnemius. So that again suggesting to us, even at this localized peripheral tissue beds, there seems to be this difference in where nitrite has an effect. So we can look at it in terms of an exercise activity and also where blood flow and where we may be having an effect. So what about if we don't have a lot of oxygen? You know, if we reduce that, that could be a blood flow issue again. You know, it's sort of related. We have less capillary density in fast twitch fibers. So what you sort of look here is looking at normobaric controls, hyperbaric controls, and then, hypoxia and control and hypoxia where they supplemented with beetroot juice as an inorganic nitrate supplementation in 2012. And if you look at this again, what you sort of see is, again, I'm sorry it's not very clear on here, but you can kind of see that when it's hard for me to see actually on this version, but we find that, you know, it's significantly reduced, so muscle perfusion is significantly reduced in the hyperbaric control group compared with the normal, and it kind of comes back given the group given inorganic nitrate. Okay, so we've looked at those three things, and we'll sort of summarize this. If you look at dosing, this is a study by Lee Wiley, the group in Exeter, and they looked at giving 4.2 millimolar, 8.4, and 16.8 millimolar, and looked here at exercise capacitance here, and then also on this side, time to task failure. And again, you can see that this higher dose, they started to have these beneficial effects, and they came up with the idea that over 5 days of dosing appears to be an optimal strategy. And then, you know, we'd expect to be giving 8.4 millimolar or greater to have the maximal benefit from this. Okay, so, and if you break this down, you know, 55% of the acute administration studies and 75% of the chronic seem to be able to elevate plasma nitrite, which is the second pass, to above this sort of 400 millimolar concentration, 400 nanomolar concentration, sorry. And I've kind of looked at that as an arbitrary line. When I've looked at the studies, it seems that if you can increase plasma nitrite to above 400 nanomolar concentrations, the studies are more likely to be beneficial. So again, you can argue that, you know, is it the change in that? Should you be looking from where they start and where they get to, and what's the delta? Or should you be looking at, do you have to reach some therapeutic threshold? And from my observation, it seems like about 400 is the therapeutic threshold you may want to be looking at. Okay, so, you know, the other issue is variability. So we have this oral bacteria that have to convert nitrate to nitrite. And we all have, and we know, research into the microbiome. There's lots and lots of interest in this area for a variety of different diseases. And so, you know, if you don't have the right set of microbes, maybe you can't convert the same way. And so if you look at this, just as an area of variability, there's healthy trained cyclists, single dose of 5 millimolar. You look at the variation, you know, so they're all starting around the same point here, and the trained cyclists, so that, you know, you'd expect them to about 300, but look at the variation in what people respond. You know, it's really wide. And so, again, you know, we've listed in a study that I sort of participated in, and I'm really sorry, when I look at this on my laptop, it's perfectly clear, so I'm not sure why it's not. But there's a list of different kind of bacteria, an abundance of bacteria here. And what this study found was that if you look at the sum of the nitrate-reducing bacteria, the percentage of relative abundance, a given dose of nitrate, you find that the ones that had the most type abundance of these bacteria that we know convert, you would think a no-brainer, are the ones that convert the most. When we've looked at this as a longer-term idea in peripheral arterial disease subjects, this is within subjects' variation, right? Taken at different days, weeks apart, and you can see that some people, nitrate levels on the top, nitrite in red underneath, there's a very significant variation in how much they convert. And we know that you can sort of affect the microbiome by a variety of different things. So people are working out now, can we test the microbiome before we try and administer? And can we sort of, if we can change that, would it be more of a therapeutic benefit? So just to give you some idea of the factors that are involved. So to summarize what we said for the clinical side of it, a lot of these people have atherosclerosis, so they're going to have endothelial dysfunction. So they're probably less likely to produce nitric oxide in the normal endogenous pathway that we outlined to start with. So it may be more beneficial to give them nitric oxide. But from the actual physiological side of it, a lot of them have reduced tissue perfusion during exercise, which would mean they'd have a lower PO2, which we know may be more beneficial. They have an increased ATP cost of activity. We know that we can maybe alter calcium kinetics. We have this sort of reactive oxygen species, and we know that NO can act to sort of counteract ROS as well. And then a lot of these groups have this reduction in type 1 muscle fibers, right? Because they're not getting a good oxygen supply, so they lose capillary density. They lose all muscle fibers, but they preferentially lose slow twitch muscle fibers. So they become a more glycolytic animal. And we'll walk you through this in the PAD example. So, maybe if we give this, we can actually start to attack this area and almost restore some of these deficits is the way we're looking at it. So again, this is the graph, but this is just the clinical populations here. So there's 28 studies up to 2020. And, I've listed them. There's more than this now, and so it's hard to keep up, to be honest, but it gives you some idea of last time I went through this, this was as accurate as I got it. So PAD, 3 studies. I've got a little asterisk, and I'll tell you why at the end. Heart failure. There was 12 studies, one in sort of an intermediate, not HFrEF or HFpEF, non-ischemic dilated cardiomyopathy is why it's in a parentheses here. But this is a really interesting area because there's 2 main parts of heart failure, systolic dysfunction and diastolic dysfunction, and these may be completely different in the way they respond to a lot of different things. So bear that in mind when we look at the data a little bit. COPD, type 2 diabetes, metabolic syndrome, and muscular dystrophy. And so what we find is if you look at the number of positive studies, you can break it down here. So we ended up with this positive rate of 53%, which compared with what we said in Senefeld's, the positivity rate was, I think we said 68 were negative studies, 68% were negative. So, when you do the math, it worked out with a fraction, 31% had a beneficial effect. So only 1/3 do we find that. So give you some idea of what we may expect to find in clinical populations. So conclusions for this first part, inorganic oral nitrate does not serve as an ergogenic aid in the majority of healthy human exercise studies. Maybe even less so if you only look at athletes. Many of these studies, however, are small, right? So we're looking at very small numbers. They've got different dosage regimens with concentration, timing, length of dosage, etc. The best results seem to be if we can get above plasma nitrite to be above a dosage of nitrate to be above 8 millimolar for over 5 days. Higher intensities that rely on fast twitch type fibers appear to be more likely to be beneficial. And then in clinical conditions, poor peripheral tissue perfusion may result in chronic maladaptations, which make themselves a more glycolytic phenotype. This sort of phenotype you would expect to be more responsive given what we know that predicts response to inorganic nitrate. And a lot of these benefits seem to be focused on the peripheral tissue beds. That may be where their action is, rather than central. So let's walk through a sort of model that we've done a lot of stuff in here with peripheral arterial disease, and we'll get you familiar with it, and then we'll walk you through sort of how, what happens when we give nitrate. So, I'm assuming most people are familiar with peripheral arterial disease. It's where we get atherosclerotic plaques, excuse me, put my teeth back in, atherosclerotic plaques in the legs, that when we, at rest, we can meet the demand of the muscle, the relatively low oxygen demand of the muscle for blood flow. But when we start to exercise, this kind of increases and the supply cannot meet the demand anymore. And this manifests as sort of ischemic leg pain. And so these folks get to walk for a short period of time at a not very quick pace. And then they have to stop because they've got leg pain and cramps, and they have to rest until this dissipates, and then they get to go again. And it's really debilitating. Give you some idea of the people that we're talking about here. We have them walking on a Gardner protocol. And they're stopping at like 2 miles an hour and 2% grade. So a lot of times. So not everybody, but you get the idea that it's fairly debilitating. And so, we can walk about the number of people, how significant is the problem. It increases with age. And, about a third of people with PAD have pain in ambulating like one block. We've defined intermittent claudication here already. Pain in one or both legs during exercise is relieved with rest. And the idea of this is the main treatment goal is obviously primary prevention and secondary prevention. They don't want to have progression of this disease state or others, MI or any of the other cardiovascular diseases. But really we're looking, can we increase pain-free walking as a major outcome? And so the way we measure this a lot of times is claudication onset time. You'll see in a lot of these figures, whereas when they start to feel pain from walking, pain in the legs, but they don't have to stop, but it's starting to hurt. And then peak walk time is usually when they get to the point that they have to stop because they can no longer continue. The pain becomes too much. So a lot of these figures. So we looked at fitness as a predicting factor. If we start to look at, well, how fit are these people with peripheral arterial disease? So I took some of our data and we've just looked at it. So this is ACSM guidelines between very poor fitness and poor fitness in blue for males and pink here for females. So what you can see with these PAD patients, they're well below this very poor fitness level, right? And this was with and without type 2 diabetes. This was a group with risk factors that didn't currently have cardiovascular disease, but not a healthy control group. And you can really see that there's a big drop-off here, to give you some idea of the fitness aspect of it. When we talk about fiber type, and we're looking at where may we have a more beneficial effect, and we've talked about targeting fast-twitch fibers, PAD is an example, and this is some data from Chris Askew, the Sunshine Coast in Australia. So remember, if you look at sort of this sort of distribution of fiber types, slow, type 2A and type 2B, in controls they saw 62, 16 and 22. In PAD it was 49, 27 and 24. So you can see that this ratio has now changed. So they're losing all fiber types. They're not just losing slow twitch, but they're losing more slow twitch at a faster rate than they are fast twitch. And again, if you're chronically underperfused, then you're not going to be able to sort of use the oxygen. It's not coming. You're more likely to become a glycolytic animal. All right, so you can sort of see that leads into this. And then Chris nicely put the capillary contacts between the controls and the PAD. And this was it was like a power measure. And again, you can see it's correlated. So the less capillary contacts these guys had, the less they were able to function. Some data from us as well in one of our papers in 2011, you can see quite clearly they've lost a bunch of sort of capillary density here. They've had this rarefaction of capillary density. And when you look at it as capillaries per millimeter, and whether you look at it as claudication onset time, or you look at it as peak walk time, there's a correlation between this, as you would expect. Mitochondrial function. How does this affect the mitochondria? Because we know that NO can have a beneficial effect on some of the complexes in mitochondrial function as well. So Pipanos looked at a study here, and again, without going into too much detail, looking at sort of O2 consumption and ATP production, you can kind of see that with the controls, much more throughput than we have in the PAD subjects. Some really small data that we did from a cardiovascular disease group versus a PAD group when we're sort of playing with this. And again, you can kind of see that this O2 flux is much lower in the PAD subjects. So, there's a target. We're not just affecting a healthy system, there's a target that we can possibly aim at. When we look at endothelial function, for how much endogenous nitric oxide are these people producing as well, or these patients, again, you're looking at the same sort of risk factor group, percent change in brachial artery flow-mediated dilation as a measure of nitric oxide production, and again, much lower in the subjects with peripheral arterial disease, suggesting they don't have the endogenous production either. They're deficient in that area. Pipanos put this idea of protein carbonyls as a measure of oxidative stress and duration of PAD symptoms, and over time you can kind of see that this is linear related. And he put a nice model together here that talks about how this can affect mitochondrial function and sort of have this decrease in function. Okay, so what do we currently do for peripheral arterial disease? We want to increase pain-free walking if possible. So there's pharmacotherapy. So mainly this is effective for risk factor reduction. There's a couple of drugs out here, but one of them that seems to affect walking a little bit is discontinued a lot because it has a lot of adverse effects. The other one appears to be no better than placebo for improving pain-free walking. Surgery, we know that we can do surgery, but what you find is even after you do surgery and open up the artery, exercise performance doesn't change to the same extent. So it's not about just, at this point when they've had PAD to this length of time, it's not about just unclogging the pipes, it's also about what is the tissue doing and how can we alter what's happening in the peripheral tissue as well. So then, supervised exercise training is a class 1A recommendation now. It is approved for reimbursement, and you can get sort of 36 sessions over 12 weeks, and then you can get another 36 sessions if necessary as well. The problem we have with this is that we really need to do a better job is a lot of the PAD people are misclassified in the ICD codes as a vascular disease, but not the subcode to allow them to get exercise therapy. So as exercise professionals, this is something we sort of need to look out for as well. So the biggest study of exercise was the CLEVER study, and they took a group of people here, and I apologize because I can't see the numbers on this, but it was like 20 to 30 in each group, and they basically looked at, if we give you the optimal medical care, treatment, they looked at stenting, so surgery, and then they also looked at supervised exercise. And they did one arm that they discontinued that was supposed to be exercise and surgery, and then with no results for that were forthcoming. So what you see is, for optimal care, these folks increase peak walk time, so not pain-free, but because you can't compare surgery when the pain goes away with exercise where you're supposed to walk at pain. So they increased 1.2 minutes peak walking time, 3.7 minutes for surgery, and no surgery but supervised exercise. At 6 months, they increased almost 6 minutes. So significantly greater distance, significantly greater peak walk time following exercise rehabilitation therapy. And then for the next 12 months, they just called them up and said, are you still exercising? They didn't actually bring them in and do anything with them. And you can see again, the 95% confidence intervals here are just touching, so it's not quite significant. But we hope we could have an enduring effect. It's sort of, it's hopeful that we can have an enduring effect. So what do we do with these people? So when you bring them in, basic idea is they walk on a treadmill until the workload, the pain becomes moderate. And I don't know if you can see this very well here, but this was my NAMAR claudication scale, and this was actually from a student in Australia that made this up. But if you've ever seen Neymar play soccer, it's the equivalent of no pain, a 1 on the scale is pain begins or discomfort begins, a 2 is mild pain or discomfort, 3 moderate pain, and 4 severe pain. So we ask them to rate themselves as they're walking when they get to this. And what we try to get them to do is walk 8 to 10 minutes at a moderate pain level here. Okay? And then they have to stop, and they get to rest, and they get to recover, and they go again. So the idea is they get at least 30 minutes out of a 60-minute session walking at this claudication moderate pain level. So what do we find? So no supplementation here. This is just when we exercise PAD subjects. And this is kind of how we got into this nitrite area. So, we were doing this, and these were the control group. Again, there were risk factors. You can see the VO2 here. I think it was up about 24. Here was the PAD subjects at baseline, and then this is the VO2 3 months after exercise training, after these 36 sessions. You can see we have this significant increase. We didn't repeat the control group, just a comparison group. When you look at claudication onset time, same thing. Following exercise, they had an increase in claudication onset time. As you would expect, they get to walk further or walk longer. And this is on a treadmill, so it's continually getting harder to do. It's not just a straight walk. When we look at brachial artery flow-mediated dilation, we talked about as an endogenous production of nitric oxide, again, we had an increase here following training. And this is sort of an interesting, what we did here is we measured what their plasma nitrite level was before a maximal graded exercise test and what it was after a maximal graded exercise test. So we saw an increase in plasma nitrite in the control group. And before we did any exercise training, plasma nitrite actually went down in the PAD group. Following 36 sessions of exercise over 3 months, it came up a little bit. So we had this significant change in this flux or delta nitrite on a maximal exercise test. And then when we looked at this, and we looked at this change, this delta, and we also looked at the delta in claudication onset time, we saw a correlation between the two. So if we could tell you how much nitrite they would produce, it looks like we can kind of predict how long they'll be able to walk before they get claudication onset pain. So that led us to say, okay, well, what do we need to do then? The obvious conclusion from here is, which it took us a little while to figure out, is let's give them some nitrite and let's see if they do better. Okay, and so, you know, this was way back in 2011, before people were giving beet juice and doing all that kind of stuff. And so we looked at lots of different foods that you could give. And it turned out that, you know, you could give like wheelbarrow full of kale that would take them a long time to eat, or you could actually give them beet juice to drink, because it's got tons of this stuff in, and it was available at Whole Foods. And so we decided this was the way to go. So the idea was we'd give them a drink that's got lots of inorganic nitrate in it. It would increase their plasma nitrite, which we've seen from the last figure. Hopefully it would have an influence on exercise performance. It would increase blood flow, because at that point we thought it was more about blood flow. There were some other physiological mechanisms we hadn't thought about. And it would increase exercise performance. These guys, there was 8 subjects when we first did this. There was 67 years old, a BMI of 28.6, and an ankle brachial index in what we call the worst pain leg of 0.64. What this means is we would look at when, it's basically similar to a blood pressure, but it's not quite the same. So we look at, you know, what pressure do red blood cells come through the artery in their arm, and compare it what they get in the foot. And so anything below 0.9 tells us there's this ratio that's not in favor of perfusion in the legs. So we really want the ABI to be above 0.9, and below 0.9 is a diagnosis of peripheral arterial disease. So you can see these are reasonably severe. So then we gave them a litre, half a litre of beet juice, Biota beet juice that we just bought from Whole Foods. It contains a lot of nitrate, not much nitrite. We gave them orange juice because it doesn't contain much nitrate or nitrite, but it's matched for calories, carbs, fat, and protein, and consistency. And as you can imagine, drinking half a litre of beet juice is not a pleasant experience. We first said, well, can we do this? Will they drink it? So let's try it. And I at least drank mine chilled, and it took me a little while. One of the research assistants didn't even try and chill it and tried to drink it warm, and it was just not a pleasant experience. But they drank most of it. So we've got some idea of how much we gave them. And what do we see? You know, if you look at plasma nitrite, the control group on the bottom, the treatment group, goes up pretty quickly. We only measured it 2 hours, but you can see that, you know, it probably went up a little bit earlier than that and stayed up for the whole time. We started the maximal exercise test at 3 hours, and then this is at the peak and after the exercise test. So the timeline's a bit condensed here, but you get the idea. Here, you can see at 2 hours it was on its way up, but at 3 hours, we think it peaked out. We had a significantly higher, and if I take this arbitrary 400 nanomolar, you can see that we kind of cross that line. So what did we find? Well, we actually found sort of like a 17 and an 18% increase in claudication onset time and time to exhaustion in these groups. So a big change, a big improvement in what they could do. We also used NIRS on the gastroc and the calf to look at, maybe we could measure some surrogate of perfusion. And what we see again is if you look at the sort of, this is the deoxyhemoglobin here in the beet juice versus the placebo. And again, we seem to have less proportional deoxy when we were looking via NIRS. And again, if you look at it for oxy, you see the other way around, suggesting that they have greater perfusion. Not a perfect measure, but it's a reasonable surrogate to indicate. So then a second study came out in 2018 with a group BOC, and they basically just gave them nitrate for a period of time and didn't do any exercise, but did an exercise test before and after, right? So we gave an acute dose, they gave it for 8 weeks, and they gave 8.5 millimolar, so sort of a little less than us once a day. And again, you find plasma nitrate went up, plasma nitrite went up, not quite at this 400 nanomolar level here. They found a reduction in blood pressure, which is always kind of one of the markers that we consistently find across populations in the treatment group, but not after placebo. And when you look at what they found in exercise, 6-minute walk tests, so this is so far, how far can you walk in 6 minutes, significantly increased in the treated group, and they used sodium nitrate. So they didn't use beet juice, they used sodium nitrate here, to clarify, and nothing in placebo. When they look at peak limb blood flow into the leg, the same thing, they saw an increase, and vascular conductance, which are kind of, with pressure factored in, a little bit of an inverse of each other. So there's improvements in both of these. And then when they put these, the change in 6-minute walk and vascular capacitance of the calf, they saw a correlation between these two. So then we did our follow-up study in 2018, where what we basically did is randomize people and said, if exercise, as an exercise physiologist, I kind of feel like if we know exercise is probably the best thing we can give a lot of PAD patients, what we really need to see is, can we improve upon that if we can supplement and use an inorganic nitrate? And so the idea was, I called it, can we beat the best? If exercise is the best, can we beat the best? Which was a kind of like moment, but hopefully we can. And so we sort of randomized these people, and we ended up with 11 and 13 to each group. And these are the people that actually did all the work. So this is Mitch Van Bruggen, who worked with me at Duke, and now is doing all the Apple Watch stuff over at Apple. And you can't see this, but it's a sub 2.5-hour marathon. And he wasn't taking beet juice when he ran this as well, by the way. Kate Ham, who ran all the vascular, Tom Stabler, who did all the biochemistry love, and then Mary Wasner, who sort of came over to Australia, is a professor over there as well. So this was who actually did all the work, and we had a couple of NIH grants to R21s to work through this. So these guys were 72. There was 13 and 11, as I mentioned, some diabetics in there. And we gave them, this time, the beet juice shots had come out, right, where you can have the placebo. So 70 milliliter beet it shot with 4.2 millimolar versus placebo. We were aiming for above 400 nanomolar plasma nitrite concentrations as a therapeutic dose. We only gave it once on Monday, Wednesday, Friday, 3 hours before they came into exercise. In retrospect, with data that's come out since then, we probably would have given it every day, and we would double the dose. But you'll get an idea of what we found. So what you find is when they were on treatment, obviously the treatment group went up and then came back down before and after the 12 weeks of rehab. And same with you look at plasma nitrite. Sorry, nitrite's on this side, but again, you can see we got it way above the 400 nanomolar we were aiming for. So what do we see? Claudication onset time, obviously we're exercising everybody, so you would expect everybody to get better, right? And that's what we saw. We weren't powered to see this as an ANOVA model, so we've kind of broke this up to sort of show for you just preliminary data. This was similar to previous studies with larger N that we saw significant, so we seem to have the same actual change. And t-test revealed that the group taking beet juice actually increased significantly. And when we looked at this as a change in claudication onset time and the effect size, so sort of an ANOVA readout to this as an interaction effect, we got an effect size of 0.62, so a reasonably strong effect size. When we did the same thing for 6-minute walk, you can see the same kind of result as well. We saw a significant increase, and again the effect size when we look at it that way was 0.4. Blood flow responses, we actually saw ABI increase, which we didn't expect, and it'd be interesting to see if we can repeat that, and a large effect size on that. And when we looked at limb blood flow with plethysmography, we see the same sort of pattern. So what I want to stress with this is, tissue perfusion responses, we had to compare them with themselves this time. So, it's kind of 0 would be no change. And so you can kind of see that here, when you're looking at deoxyhemoglobin, there's not much change in the control group. Oxyhemoglobin, not much change. Sorry, in the exercise group only. But the exercise and beet juice group, we saw this fall in deoxy and a relative rise in oxy, giving us an idea that they had better perfusion as well. So what I want to sort of say when we finish this is, remember, we're looking at this is the best treatment. Can we do better than the best treatment? So, you've got to show a big beneficial effect, large subject numbers, and we're hoping to kind of follow that up with larger trials to answer the question definitively. So summary of PAD studies, these were the different, I really put this in here for the different doses to show that, what were the increases, and some groups increased more than others. Plasma nitrite was a little bit lower in box group. What we gave people, there's that variation. But all these studies increasing an exercise outcome, whether it's 6-minute walk, claudication onset time, VO2 peak, time to exhaustion, time to peak walk time. Another study came out this year by Van der Voort and Marie Hopman out of Europe, and they didn't see an increase. So they looked at 6.5 millimolar of NO3, either beet juice as a diet, a normal nitrate-rich vegetable diet, or nitrate-depleted beet juice as a placebo. They didn't see a change in claudication onset time. They also didn't see a change in peak walk time. The only issue we have with this is, measured 2.5 hours after, both the placebo group is actually higher than the nitrate-rich vegetables group, and they're all above 400 nanomolar plasma nitrite concentration. So maybe they're actually all having a beneficial effect, and it's hard to differentiate it. So conclusions to part 2. Let me just see how that. So conclusions to part 2. Many cardiovascular disease states are characterized by failure to match oxygen delivery to tissue demands during physical activity, which may allow for greater efficacy of inorganic nitrate to improve exercise performance. The effects seem to be at the tissues distal to the site of stenosis, where oxygen delivery is determined. That biggest drop off in pressure and largest volume, and they tend to become more hypoxic during physical activity. The levels of plasma nitrite seem related to the exercise performance. Acute inorganic nitrite supplementation appears to produce increased exercise performance. Chronic also increases exercise performance, and our preliminary data suggests we can actually add to rehabilitation exercise and have a more beneficial effect using nitrate as well. Despite exercise training alone delivering substantial improvements in people with PAD and intermittent claudication, our data suggests we can actually increasing plasma nitrite prior to exercise may allow these subjects to train with less pain each session at higher workloads for longer durations, thereby maximizing the beneficial adaptations. Okay? Very quickly, what about nitrate and nitrite in the muscle? Because this is a pretty hot topic now. There's only been 1.5 papers out there. I call it 1.5, and I'll tell you why. But there's been 5 reviews, which is kind of, in humans, there's only been 1.5 papers. In rats, and we've partnered with Barbara, who's done most of that work. But the idea is, can we store nitrate and nitrite in tissue, muscle tissue, and then use it afterwards? So, it would prolong the beneficial effects. And if we chronically administer it, do we load up? So, and then you can have the biological effects. So, this is a paper by Wiley in healthy young subjects, and they had 12 healthy young subjects, and under no supplementation, it seems like these guys had this potential gradient of nitrate and nitrite that could move from the muscle to the plasma. I'm not saying it does, I'm just saying the concentrations between the two have this potential for a gradient. When we looked at our PAD subjects and nitrate, and we looked at heart failure, systolic dysfunction heart failure, we didn't see this, right? And the numbers are much smaller as well. So as you're looking here, they're also much smaller concentrations. The only one that there was a gradient in peripheral arterial disease was for nitrite, but it's so small. We're looking at 0.4 here versus 7, right? So the actual significance of it being a difference, a significant difference, is probably pretty low. So what happens when you supplement, and we summarize this, here's the peripheral arterial disease, here's the CHF on the same scale. Here's the type 2 diabetics that they only measured nitrate, giving sodium nitrate. And then here's the healthy studies from Wiley's group. And again, much greater nitrate in the muscle. Nitrite didn't significantly increase after supplementation. So it was higher to start with in healthies, these two groups, and nitrate went up in everybody. Nitrite didn't increase in anyone. So it's kind of interesting that, and then when we've sort of looked at these relationships between plasma nitrite, nitrate and muscle, we see correlations between the two, suggesting maybe there is some communication between the muscle compartment and the plasma compartment for nitrate. We didn't see it for nitrite. We also didn't see it when we tried to compare between different species as well, muscle nitrate and muscle nitrite. So it kind of suggests to us that maybe you can store some of this as nitrate, but it doesn't seem like it can be converted to nitrite in the muscle. Maybe it has to go into the blood, through the circulation and saliva, and get converted to nitrite to be used. These studies in healthies didn't show an increase in exercise performance despite elevated plasma and here muscle nitrate levels. So they didn't show a beneficial effect on exercise performance. So bear that in mind when you're looking at these reviews and effects on exercise. You actually have to have an effect on the outcome to claim that it's beneficial. We saw an increase in PAD, and we only had a subset of the heart failure patients, so we didn't see it in those. But in the bigger group, we actually did see a benefit, so who knows? Okay, and Barb Picknova at the NIDDK has done most of this work in rats, and she partnered with Lee for these guys, for the earlier stuff, the healthies, and partnered with us to look at the PAD and CHF. Okay, folks, I'm done. And look at the beautiful campus of the University of Virginia. We have to show you this picture. It's written in our contract at the end of any presentation.